Um, so welcome everybody to our monthly rounds. I'm going to be moderating and chairing this meeting. And we're very pleased to have Dr. Liisa Jaakkimainen here. To start this session, I'll just give a brief land acknowledgement. As a Métis person, I acknowledge that we are on the traditional territory of First Nations peoples. May we honor their enduring connection to the land. And so just by way of introduction, Dr. Liisa Jaakkimainen is a family physician, and you can see her there in clinic as we speak. And importantly, she's the lead of primary care and population health at ICS, which is the health administrative data that we have here in Ontario. She's also the lead of Popular, and this is a network of practice-based learning networks affiliated with all the departments of family medicine, and the CHC organization, the Alliance, also has an EMR network. So welcome, Liisa. Today, she's going to be talking to you on the ecology of healthcare. There's an important background to this. This initial study was initially published in 1961 in the New York Journal of Medicine. It was done by a Canadian, K.L. White, very important. And basically, K.L. White came up with a framework for thinking about the organization of healthcare and research. And a lot of people have reproduced this infographic and this approach. And then Liisa and her group have taken this and extended it in trying to help us better understand how primary care is set up and organized within the province of Ontario. So it's really fascinating work and very much at the forefront in terms of what health policy people are interested in terms of how we allocate funding and what are the important areas in which the healthcare services are provided. And so with that introduction, I'll just make one other comment. People who know Liisa know that she's also a resident of Redendale. And on that note, I'll hand it over to you, Liisa.
Yeah. Thank you, Elliot. And thanks for having me come and speak. I apologize. I've been meaning to come and talk, and this was finally a time that worked out for everybody. And I guess I'm just going to wait for the first slide to go up. But this is some work that we started as part of the Inspire PHC group. And it's, as usual, it started off with one infographic, which led to more questions, and then led to some more work, which led to more questions. And I just want to demonstrate a process that sort of happened with doing this. I just wanted to acknowledge, other people on this study, and mostly Paul. Paul did all the analysis for this study. And now I don't see anything. Oh. That's it. That's perfect. So again, just want to recognize Paul. He did a lot of the analysis, and as all analysts do, they go back and forth when we change our mind about how do we want to code things. But thank you, Paul. Anyways, and just to say that this study is funded. You can do the next slide, Elliot. This study is funded by the Ontario Ministry of Health. And obviously the views of this analysis are those of the researchers and not particularly those of the Ontario Ministry of Health. I feel like we're saying this a lot these days because sometimes they don't really like what we're finding in our research. So I really want to make this disclaimer. So the next slide. And the next slide, please. And as Elliot pointed out, I think ecological analyses are a very general concept to describe looking at assessments of relationships between individuals or groups and their environment. And the idea is to see individuals and groups as part of a bigger or larger system. And this was first done in 1961 with the White analysis that was published in New England Journal of Medicine. And I'm so happy to say it was published before I was born. Yes. And it was also replicated again many decades later with Larry Green. And the idea was to look at the basic concept is the availability, the quantity, quality, and distribution of contemporary medical care meeting the needs of healthcare consumers. I mean, that's the overall big picture. Moving along later, using sort of medical panel survey data, and again done in the United States, it was starting to look more granular at like physician, primary care visits, specialist visits, emergency department, inpatient, dental visits, home care visits, and was starting to look at these things by age category, sex, health status, and the Americans have the big advantage of looking at least race, where we're challenged at a population level to do race and ethnicity. And then we have Moira Stewart and her group, and I can't remember who else. I just blanked. Anyways, Moira and did another study also looking at ecological analyses, where she linked the Canadian Community Health Survey to CIHI data to look at the frequency of physician and specialist visits and nursing visits in the presence of people who identify with certain comorbidities. So again, it's looking at visits by certain categories of people. And more recently, Alberta used routinely collected health administrative data that was linked to different types of surveys, including their triage system, to actually evaluate policy. They wanted to look at what was happening in primary care because they had restructured their primary care, and was this actually improving access to aspects of primary care. And if you put on the next slide, this is coming from this Alberta cohort study. Yeah, and this is where they, looked at time trends. So they looked at, percent of adults with visits to primary care, specialist visits, emergency departments, hospitalization admissions. And, whereas in some aspects, everything was very stable for specialist ED and hospitalization admissions, it was kind of coming down for primary care physicians. So this is like your first, like, uh-oh, what's going on? You do the next slide. Next slide comes from work that we did as part of Inspire PHC. And this has a bit of an Ontario context. So 20 years ago, when we had started primary care reform in Ontario, and there was massive amounts of funding and restructuring of the primary care system, we produced the Primary Care Atlas at ICS. And in that atlas, our very first infographic was looking at this, the ecological assessment of what happens in Ontario's healthcare system in 24 hours. And we produced this sort of infographic, and I always call it the infographic of ODA. It was so obvious that most people access, family physicians, if you look at a slice of a healthcare pie. But it was important to do because at that time it surprised people, including, I'd say, a lot of researchers that I work with at ICS. They were sort of like, I didn't realize people saw family doctors more. I thought they saw old people saw geriatrics. No, they don't. When we did it by geriatrics, it was like still family medicine, this little sliver who saw a geriatric physician. So I think it's important to sort of stand back and look at the whole system and see what's happening. So we did this just, last year, or a year or two ago. We said, well, let's see what's happened. We'll repeat what we did in 2006 and see what the difference was. And this is where our first surprise was, oh, well, not surprisingly, again, there's 141,200 family physician visits in a 24-hour period in Ontario. There's 71,200 specialist visits. And you go down to, there's 130 hip and knee replacements done in 24 hours in Ontario. Again, where the focus of all our research is the hip and knee replacements, admissions and CT scans, and emergency department visits. And in fact, there are 10 times more family physician visits in a day in Ontario than there are emergency department visits. But then we looked at the data, and Elliot remembers this. We said, oh, there's something kind of wrong, because everything else has gone up a little bit over 20 years, and those family physician visits don't look, they haven't gone up. So we said, oh, we checked our analyses, went back, look at codes, compared what the OMA defined as visits. And I think this has led to our next body of research, is why is this happening? So thanks, Elliot. So we wanted to do this study to examine time trends in the average number and type of healthcare services accessed by Ontario residents in a 24-hour period. And we wanted to investigate these time trends by number and type of healthcare services accessed by Ontario residents living with specific chronic diseases such as diabetes, hypertension, congestive heart failure, COPD, dementia, and cancer. And the next slide, please. So we have a cohort of all Ontario residents. We were able to take the whole population, which is very unique in having population-based data when you look at, for example, the American system. And we use this linked administrative data and standard measures of healthcare utilization. And our healthcare utilization, we looked at family physician visits, which did in this analysis include nursing home visits and long-term care facility visits and home visits, but it excluded ED visits and hospitalizations because they're included in hospitalization visits and ED visits. We looked at physician visits, x-rays, CTs, and hip and knee replacement. Next slide. So we picked these chronic diseases just because it was low-hanging fruit. We have at ICS validated health administrative data algorithms for diabetes, hypertension, CHF, COPD, and dementia. We didn't want to start picking chronic diseases of which we don't have fairly accurate algorithms to identify them at a population level. For cancer, we included all diagnoses of cancer. We just lumped them together, but we linked to the Ontario Cancer Registry. We spent a lot of time looking at FP visit codes. We compared differences with some of the estimates the OMA had, and we ended up including more certain types of codes that weren't used in previous analyses. And then we looked at the average number per 24-hour of selective weekday, weekend healthcare visits per fiscal year for each Ontario resident from April 1st, 2002 to March 31st, 2024. And then we did an average for each year. We also looked at population average per 10,000 population. And this was our first study. Again, this is where it was based on that 24 hours in Ontario's healthcare system. And we looked over, dismiss all my messages here, and we looked over and said, oh, so we had the top line, the dark blue line is family physician visits. The lighter blue line is specialist visits. And near the bottom, you'll start seeing hospital admissions and teal, ED visits, x-rays. And you can definitely see the more expensive and more costly parts of the healthcare system are at the bottom. It's definitely still family physicians are always most commonly accessed a healthcare provider in the system, followed by specialist physician, and then the lower end are hospitalization ED visits. You can see though that family physicians like, oh, they're kind of stable, and look at the specialist visits are kind of going up. And you know, if you take COVID aside, that little funny little bleep you see with COVID, you know, other things are sort of gradually going up, but not, you know, gradual. This is an eyeball. So we said, well, why is this happening? So next slide, please. We decided to not look at visits, and we decided to look at population. So we said, well, what if the denominator is not visits, but actually the population of people in Ontario? Because as we all know, the population is increasing in Ontario and in certain parts of it. And this is where we went, oh, this is not getting better, it's getting worse. So if the denominator now is the average number of visits per 10,000 population, you can see, well, you know, it's still, you know, family physicians are still the most access portion of the healthcare system, but that trend is going down. And interestingly enough, the trend for specialists is slightly going up still. So next slide. So we decided to slice and dice it a little bit. Now we're starting to let's look at age groups, just age groups. And what we did in this slide and the subsequent slides is we looked at visits on one axis, and I'm just going to try to get my notes here. Visits on one axis on the, I don't know, the average number of visits per 10,000 population and the average number of visits. And the two broken lines are looking at the family physician visits versus the specialist visits. And the other solid lines are actually looking at per 10,000 population. So where you can see for children, for example, from 2002 to 2024, you see the population for children between 0 and 18 is actually pretty stable. So it's 2.84 million to 3.03 million over that 20-year period. And the average number of family physician visits slightly decreases from 20,700 to 15,100. So you can see, oh, it kind of parallels that. Next slide. Now, if you're looking at adults between 19 and 64 years, now the population increased over 20 years from 7.5 million to 9.45 million. Overall, the number of family physician visits is pretty consistent and stable over that period, from about 80,000 visits to 86,000 visits. So it's a fairly stable change. Next slide. And this is where we see something different. So if you look at the population for people 65 and older, and most of us know this is not surprising, the population over 20 years has almost doubled. So it's changed from 1.47 million to 2.83 million. But it's interesting because if you look at the family physician and specialist visits, they've increased. So they've increased from 32,700 to 41,800 visits over that 21 period. So family physician visits have increased. And if you just looked at visits, which I did before, I said, oh, but the visits are going up because the population is getting older. But it's still not meeting the demand. The population there's a crisscross. So if you go to the next slide, and then we started to look at certain chronic diseases. So we're looking at people with diabetes, and the population of people who living with diabetes has increased 2.5 times, from 652,000 people starting in 2002 to 1.6 million. It's huge. And the number of family physician visits have increased from 15,800 average to 28,100. But again, it's the visits are going up, but if you use the denominator's population, it's going down for family physicians, and it's pretty stable for specialist physicians. Next slide. So looking at hypertension, population of people with hypertension has gone up 60% from 1.98 million to 3.28 million. The number of family physician visits has gone up from 43,700 to 52,700. We go to the next slide, looking at congestive heart failure. That population's also gone up 50% from 240,000 to 304,000. And the number of family physician visits are pretty stable from 6,200 to 7,100. Next slide. And when you look at COPD, another population that's increased over 20 years from 582,000 to 922,000. And the number of family physician visits are pretty stable, about 14,300 to 17,100, a very stable sort of analysis. And then finally, when we look at dementia, so dementia has also, population has doubled from in Ontario from about 100,000 to 211,000. And the visits have increased. This is where, again, you think, okay, that's good. The visits have increased, but again, it depends on your denominator. Visits have increased from 5,400 to 76,000 visits per year. And finally, when we look at cancer, this is kind of a big category. I mean, there's lots of cancers, and we could be more specific on the types of cancers. But the population over 20 years has doubled from 373,000 to 764,000. And the average number of visits have increased from 8,100 to 130 visits over the time period. So there is some increase, but it's not quite meeting some of the population demand, I would say. Next slide. So then I think the interpretation of this is, family physicians still remain the most frequently accessed service in Ontario's healthcare system, no matter how you slice it and dice it by diseases or by age groups. While the average number of family physician visits per day increased for people over 65 years of age, people living with dementia, hypertension, cancer, and diabetes, the average number of visits, family physician visits per population decreased for all these age groups. Next slide. And it's interesting because the gap between family physician visits per day and specialist visits per day is narrowing. So there is an increase. There's a specialization that's starting to happen in our healthcare system. The average number of visits per day for specialist visits increased as did the average number of specialist visits per 10,000 population. The increase in specialist physician visits per population slightly increased for people over 65 years of age and for persons having hypertension, CHF, and COPD, and dementia. And that's it. It's just a very high level slice and dice. It kind of, one cut of the pie led to why is this happening? And then we would cut it and look at it over trends and go, why is this happening? And I think it's this sort of like many ecological analyses sort of leads to more questions and some more analyses that I think we're going to be looking at.
It's great, Lisa. What a great overview and excellent overall picture of the health system in Ontario. One of the things that struck me about it, just the wealth of data that you have in there, just in terms of the patterns of healthcare over time. It's just a really rich source for hypothesis building, but also new studies and what we should be focusing on in terms of health policy.
Yep.
Yeah. I don't see any questions in the chat. Helen, you have your hand up there.
Yeah. I'm not a healthcare provider, so I'm a community person. What's the access to a specialist? I mean, my perception is you have to get to a family physician first, or I suppose to an urgent care or an emergency room to be able to access the specialist. I don't know if there are any other routes.
That's true. You have to get, I mean, it's a referral system. We don't have, it's really don't have direct access to specialist physicians. So it's still, it could be that the people that are coming and getting referred are potentially getting managed a bit more. I mean, one idea is it could be managed more by a specialist physician because you know.
Yeah. It raises some interesting questions, doesn't it? And
yeah.
I'm just talking from my own personal experience. For a number of years, had a family physician who was a sole practitioner, and toward the point where I developed an aversion to seeing her, not because I didn't like her as a person, but because I couldn't get an appointment with her without me knowing she was going to refer me to a specialist for something.
Yeah.
And it rarely, if ever, turned out to be anything serious. I am now in a family practice as a patient, and I rarely see my doctor. Most of what they offer me is preventative. I have chronic hypertension, and they take my blood pressure every now and then to make sure I'm okay. So I start to say out of that, is the propensity to refer to a specialist very dependent on the philosophy of the family practitioner?
That's a great question. I think there are factors that sort of dictate how certain family physicians have higher referral rates than the average family physician. I think there's definitely factors of comorbidity. You know, if you have a practice where you have people who are sicker, you're probably going to have higher referral rates. But we also know practices that have larger volumes, like you have you're managing a panel. Panel is sort of like a number of patients that are under your care. So if you have a higher panel size or you have a lot of patients who are rostered to your practice, you tend to refer more because you didn't have the time to actually,
Oh, exactly. And you're
you
trying
know,
to do something for them, right?
right?
The other factor, though, that I wonder is if, for instance, when I show up at our family health team office, I usually see a nurse practitioner,
Yeah.
whatever it is that I've shown up for. Um, it- but I'm thinking back to the sole practitioner. Is she, because she's working in isolation, is she more likely to be risk averse? And
Oh, well, that's a good question. Well, we know women
yeah,
are. Women physicians, there are differences between women physicians and men physicians, as another example, where women tend to be higher in their referrals than men.
yeah,
So,
okay,
and that could be a philosophy of risk aversion as well. And
yeah,
also, so the type of practice, whether you're in a team, for example, I saw a question in the chat. If you have access to other health providers like a nurse practitioner or a nurse, you may not need to refer because
yeah,
you can, like I work in a family health team here. We have a diabetes team, we have mental health supports, we have nutritional, so we have pharmacy supports. So sometimes I have that sort of backup, so they're going to be managed within our team.
yeah, yeah. I think I can appreciate that it's really hard to measure this or determine this, but it is an interesting way of saying that maybe family health practice is better in a whole, I mean, I'm quite convinced it's better, but in a lot of ways that some are much more difficult to measure than others, but it's really interesting to think about it.
Yeah, I think that's kind of what we're doing is we're trying to, and I'm also very conscious of not of appreciating their differences that we can't measure. So I think I don't like to be too judgy. It's very easy to, when you're part of a team and you're so well supported with respect to other health professionals, to then start judging people who have less infrastructure support. I mean, that's just not fair. You know what I mean? I think, and also there's differences in I have an older practice, so it's harder for me to take care of 500 people than maybe 500 healthier younger people, for example. But so there's always sort of innuendo, and you have to assume differences in styles and access to specialty care. I'm in Toronto, I'm in a teaching hospital versus in a practice that's, you have to drive 4 hours to see a dermatologist, for example. So lots of differences.
Great questions, Helen. Tricia, you've had your hand up for a while.
Thank you, Lisa, and thanks, Elliot, for the introduction and for the presentation, Lisa. Really thought-provoking. And I think I'll echo a little bit of what Helen was saying. I think my first question was around how was multimorbidity handled in the analysis? So if I'm a patient with multiple conditions, was I counted twice versus some effort to look at multimorbidity more together? And just wondering how that was handled.
Good question. And I love it because I actually think where we're not paying enough attention is on people with multiple health conditions. So how it works is this is a silo thing. So it's all people with hypertension, but you could also have diabetes. And all people with diabetes, but you could also have hypertension, which happens a lot. I mean, they're not excluded. These are not mutually excluded groups. I think the challenge and the reality of healthcare right now is we're not one condition, or we're not even a medical condition. We're kind of a health and medical condition. And so I think that is the next sort of challenge is how do they define multimorbidity or comorbidity and is to get the big data, the health administrative data to accurately reflect that. There's some work going on that.
Yeah, because that to me would be very interesting to see, like, I guess by one of those definitions, like what those frequency counts were for people, not just by age definition, but by multimorbidity status. The other thing that the last question I had, which I was really curious about, seeing that dip, people weren't going to family doctors, weren't going to specialists, weren't going to emergency rooms. And I guess we can infer that's pandemic related.
Yeah.
We're told not to go unless it was dire and you really needed to be there. But it made me wonder, to Helen's point about my family doctor is my prevention space, or my primary healthcare nurse practitioner is my prevention space, and I wasn't going into prevention. I'm wondering about the degree to which ICIS data could look at long-term impacts of those closures and of those directions, and what impact does that have on health outcomes, and what work might be going on in that space. I guess I was curious about.
And it is happening. I think there's no doubt there was a reduction in some mammograms and PAPs and things in preventive and interesting pickup diagnosis of dementia. We noticed the incidence of dementia did a dip because you weren't accessing care to get that diagnosis. Things have recovered, but there is plans to look at, well, what is the long-term health effects of cancer screening, for example, some of the cancer metrics. Has it meant women are showing up later with a more advanced cancer? So I know that work is happening with some of the cancer people.
Great question, Tricia. Catherine, you had your hand up.
I was just picking up both on what Trish and Helen were saying. Lisa, I always find it so fascinating. I've used that infographic from your 2006 work, so it's exciting to see it updated too. And it makes me, like yourself, just raises so many questions that you could layer on. And I'm so intrigued. Like, I would be so intrigued to layer actually community-based services onto this.
Yeah.
Because I would like to see if we have, the rhetoric is like, community-based services, that's where we need to put all our efforts, but we don't really layer it on top of everything. I'd be so intrigued.
Well, that's a really great idea, is to look at like CCAC, or now Lynn, I still call it CCAC, Lynn
Me too.
services. And I think that's something we could add, because I think you have to put it on there because it gets people's attention, even if it's a tiny box. And then you have to say, if it's a tiny box, does that make sense that it's a tiny box? You would think community-based services should be bigger. I mean, that's another advocacy sort of point to talk about as well.
And the thing about the community services, I know I don't want to go down the rabbit hole of like our lack of data in primary care about the non-physicians, because I know we're not there yet, and that's something that it would be interesting to layer, but that's where you could get the other service providers, because I know in the RIE data, you can actually identify like speech, physio, social work, OT. So you could actually not only lump and clump community services, you could actually see by discrete. And I think it would be particularly interesting because of the aging data.
Yeah.
Because, when you look at the discrepancy, and I'm always shocked at how much focus, and I mean, it makes sense not to take away from looking at multimorbidity, comorbidity, chronic diseases, but there's such less focus on aging, actually, I see in the primary care literature, when all of the data suggests that we need to explicitly add aging, like older adult care, to that work. So I think home care services, we know a large proportion of older adults are getting those. So anyway, I'll stop talking and let anyone else add.
Catherine, your idea
those are my thoughts.
Do the infographic for people over 65. I think that would just do that, and then look at some of the addition of home care services, and if we can, that would be very good. I like that. See, I always get good ideas when
so many questions. Thanks, Lisa. That's excellent.
But I do want to bring up that point, and I get asked this a lot, and I have been asked this for 20 some years, as nurses and nurse practitioner data. Would love to have nurse practitioner and nurse practitioner nursing data, because, again, I've worked alongside nurses for my whole career. It is not available. The encounter data is not easily available. There are pockets. In the CHCs, there's some more granular data about who provides care, but in our big system, it's not well captured, and there's more work being led by Jennifer Rayner to sort of change this and get that information out there. But I think that would help a lot, because we know anecdotally a lot of people in this province do not have access to nurse practitioners and nurses.
And just on that point, and to answer Colleen's question, I do know that the ministry is acutely aware of this, and there's a new attachment algorithm coming out which looks at measuring who does and doesn't have access to primary care, and the ministry is really keen on capturing nurse practitioner visits and trying to get that measured and to share that with ICS. So that is under. There's been a number of other comments in the chat. I don't know if Mayor Sanim, you want to comment on or do you want me to read your statement? You just did you want to?
Yeah, I mean, you can read my statement as well, but I think what I was trying to say was captured by what Dr. Donnelly said as well, is like, what about the other healthcare providers, especially physiotherapists, occupational therapists, speech language pathologists? Like, what would be the trend if we look at sort of like an ecological trend in terms of other healthcare providers? There are many different models that patients access these other like allied health professionals. They can be referred to, they can be part of the primary health care in some settings. So yeah, it would be really interesting, like if we can get a hold of data about those visits as well, and sort of like overlay these trends in terms of family physician visits, and then like how much of that trickles down to physiotherapy, like on top of the specialist visits, how many patients see physiotherapists for or occupational therapists for their conditions as well. Yeah, it'd be really interesting to see. Yeah.
And I know Catherine is very attuned to the difficulty of identifying what's in family health teams. You know, we have all these family health teams, but we still don't have a very easy and consistent way of identifying who's in each of these teams. And that's, it sounds so intuitively obvious, but I know Catherine has done a really good analysis on getting that information. And I also, and again, it will really put a perspective. Again, it's not to say, I think when you're part of a team and you're very happy, and I'll always say, to be honest with you, my patients will probably say that the person that they love the most in this team, it ain't me. It's our receptionist. I have a phenomenal receptionist who is, and I don't know what category you put her in. She's the first line. I always say to people when they join a practice, if you really want to, she's the boss. Like she manages so much. And don't be nice. You don't have to be nice. Be nice to her, because she manages this team. And then the nurse that I work with, and I kind of come along at the end, but it's really a team that works well. Is you can just see people you're happy. People that come here are happy. They feel listened to, but to get that information. But here's my pitch. Here's my other hat. It's there. We just have to work in other formats. And this is where, talking about Poplar, and I think this is where we need to start digging in the notes of what happens when you come here and I'm typing away or using stamps or whatever I'm doing. It's in the EMR. It's not structured. You're never going to get a family doctor or a nurse practitioner or anybody to code things the way we want them, because quite honestly, we have another agenda when people are coming to see us. We're doing care, but it's there. And we have the ability to use that information to really show the wealth of care that's done in primary care, in healthcare teams. And I also, when it comes to, Trisha's comment about, you're not just, hypertension, you're diabetes. I know I bill one code at OHIP, and sometimes it's just the codes. That's why diabetes is well represented, because it's 250 and I can remember 250, and 401 is hypertension. And then, 715 is OA. But my notes have so much more information on the different issues that are being covered in a visit. And that's a bit more information on multimorbidity that we're seeing in primary care, and why there's work, why it's more work to take care of certain individuals than other individuals. And I think this is where my pitch is, we can't wait for any sort of provider at any level of the system to start coding data for our convenience. It's just not going to happen. So let's take advantage of systems that are already created for our own clinical care, and confidentially, and respecting obviously privacy of individuals, both absolutely patients and also their caregivers. But we can get some information out of there. And we have now tools that we didn't have 5 or 10 years ago to actually use that quote messy data. So that's my other pitch.
You're just on mute, Elliot.
Sorry. So this is from the chat, Lisa, from Sophie Chan. With
Okay.
increasing concern for workforce challenges on the provider's part and also increasingly complex patient profiles, do you feel it will become unsustainable to provide comprehensive longitudinal primary care? And either
No.
from your personal experience or from the data?
I think if we have a system that, and it's not just, you know, Helen, you brought up the solo practitioner, and I have enormous respect for solo practitioners because that's a lot of weight on your shoulders. But I think if we support team-based care, we can have that comprehensive care provided. And I think we have to, that's kind of the way to go. I think the idea of being one individual who could be everything to a bunch of population or a bunch of people is just, it's not sustainable, and it's so complex. Even in the years I've been in practice, it's medicine is what used to get admitted when I was a medical student. I manage in the community now, and so it's not just having teams, it's also, and to Catherine's point, we need to really invest in the community. I mean, people, I work in a trauma center hospital. We have all sorts of, I call them ologists. We have, the best specialists we have super duper cancer center. We have, brain sciences center. But I have to point out to my CEO, who's a wonderful person, I just say, most people don't live here, right? They live outside of here. And we put so much emphasis on this, on the hospital system. We just don't put enough on community services. In my experience, they're talking about people who age well, they have a little bit of support, don't have to do a lot. They need a connection and a little bit of support, and they can stay home. But we just don't emphasize it enough. And sometimes that little bit of support is just too expensive for an individual to take care of. So we have to, I think we're going to still have comprehensive care because it's a great way to practice medicine, and a lot of people are interested in doing this. It's just restructuring the support, and quite a little bit of acknowledgement that's a lot of work would help too. But I think that's a culture.
Thanks, Lisa. There's another thoughtful comment by Francine. Francine, did you want to unmute and just unpack your chat comment there a bit, or?
Hi. So thank you for the presentation. I'm part of a family health team, and I also sit on the board of directors of the Association of Family Health Teams of Ontario. And as we try to advance team-based care for more patients within the community, one of the big issues we run into is that there is very little methodology for which to collect information about the IHP contributions to our patients' care. So, for example, I was having a conversation with our lactation consultant. She runs a weekly drop-in for new moms. They come in, she supports the breastfeeding, she helps them with any issues they have. She can see them a few times throughout the week. She'll bring the babes in for weighing. All of that doesn't get counted because it's a salaried person, and therefore there's no way to count what she does. But how many patients does she, just her alone, keep out of the emergency department? Right? Same with our social workers who see our patients who are vulnerable and struggling. And again, like, this is one thing that I think we're lacking. We're missing that perspective of what is the richness of team-based care? Because for sure, physician billings are captured. And I mean, those are telling, but they don't speak to those other outcomes. So those are just some of my thoughts.
And I agree with you, Francine, and this is where I'm thinking, but they write notes and charts. And in most family health groups, like our dietitians write a note. Well, the note is in their EMR, or when they consult our pharmacist, the note is in the EMR. This is where we have to, I hesitate about saying, oh, well, we need, and this is where there's a school of thought is saying, okay, we'll have the lactation consultant start doing encounter data and send it to the ministry, which is definitely a way to do it, but it's also work on the, like I said, the busy lactation consultant. But if they have a note in the EMR and we have abilities to identify this note is done by a lactation consultant, and so many patients in this practice who are, who've just given birth are seeing the lactation consultant. And of those people who are seeing the lactation consultant, they're not going to emerge because people who don't have access to a lactation consultant are for mastitis and things like that. So I think this is where, if you ask where we need to go, is we need to take advantage of, I call it information. It may not be research ready data yet, but information that is being captured in the system, and be a bit more creative in using it.
Something else I could mention too is that our lactation consultant also sees community patients. So
Right.
it's open to the community. So many unattached patients take advantage of some of our drop-in programs because they're open to the community. So a lot of FITs throughout the province are doing this, and it's difficult to capture that data as well. So just some
But
thoughts.
she still has to write a note, and you'll know that patient is actually not part of the FIT. That patient is an unattached or somebody who does not have a regular I mean, there's some ways of sort of linking data where you can use the advantage of health admin data and where people are going and having outcomes, and the information that's held in different EMR sources. And I think it's not perfect, but it's really better than nothing, because I agree. I think of our social worker that does an enormous amount of care. Our mental health navigator is worth his weight in gold, in my opinion. But again, how do we, and I think where we need to think about it and not be so shy is we're in really hard economic times now, and there's going to be some really hard decisions making, and healthcare is in there. And I think at some point you have to demonstrate the wealth of work that's done at teams. And I don't think it's always being presented. It's people talking about it and doing focus groups and surveys, which are very important. But I think if we really want to grab attention, we have to start demonstrating. Do you realize that, half of the work that's done by our full-time OT is done by people who are in the community and not part of the practice? That's important stuff.
So that's really interesting, the ecology of team-based care. I know that's not one of the directions that we had on the schedule. So just for everybody on the call, I'm part of the project team, and there are next steps involved, but certainly we can add that to the discussion. It's methodologically, it's a bit messier than some of our other health admin techniques, but just because it's messy doesn't mean it doesn't be done. Catherine, I know you've pioneered some methodology in terms of looking at IHP data within the EMR. And there's also other methodological, looking at audit logs. That was another approach to looking at EMR and looking at IHP and their footprint in the EMR. So Catherine, your comment there about bringing in IHP data into popular, this, poor Lisa, she's getting hit with this. I know she's also the popular lead. She's putting on the other hat. So maybe, Lisa, I will put you on the spot. You can put on your popular hat and talk to that comment from Catherine.
Absolutely. I think, again, we're so physician focused because that's where we have data. And again, it underrepresents and underemphasizes the care provided by many others. I'm going to talk about, she can't hear me, Chandra. Like, honest to God, she provides so much care to people. How do I represent that as being very important? So I think, yes, I think we should not limit ourselves to just family physician EMR data. I think we should bring on all EMR data and do it in, again, organized, thoughtful, definitely privacy and confidential way that we can work with it, which I think we can do.
Right. So I think I've covered all the comments in the chat. Any other comments? There's a number of people online. We have a few more minutes left for any other questions. And Lisa, you might just want to tell the group as well next steps. I know you have a paper in process to publish, but maybe just comment on next steps that we have planned here.
Yeah, I think one thing is that we're sort of diving down into the day in the life of a family, a family physician in the respect of looking at community-based family physicians, the type of care that they also provide, for example, in the home or in long-term care or delivering babies or working in the emergency department. That's something else that we're doing. Again, very physician focused, but I Catherine, I really like your idea of looking at that, a day in the life of people over 65 in Ontario. Could even do it people over 85 in Ontario and just really emphasize what we already have in some existing community resources, because I think that will really be important. There's lots of stuff. There's just, I never stop having questions, never get bored, that's for
Yeah,
sure.
it becomes a bandwidth issue and a funding
Yeah.
issue too. Like those are great
Oh, yeah.
studies, but so someone's got to lead them and someone's got to fund them.
Yeah.
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 Yeah, we'll definitely add them to the list. Yeah.
The wonderful comments are really, really thoughtful.
So Colleen, did you want to jump on and just comment on this is your second comment, but jump on and ask Liisa that yourself if you're okay with that.
Yeah, absolutely. Sorry, I'm just recovering from a cold, so my apologies for my voice. That's why I was, but I'll do my best here.
I feel your pain.
Yeah, daycare, right? It's unavoidable. Anyways, I was just wondering, so I was recently listening to CBC and they've talked about this initiative that a couple municipalities have come out with, one in BC and then another one in the Greater Toronto area, about bringing in these family healthcare teams, but the municipality would be hiring the physicians, essentially, I think a salary-based model, and then the administrative work would be taken on by other staff. And I was just wondering what your thoughts are on what this could do to our data if this model were to kind of take flight and really get some traction.
Yeah, I think it's, everybody's trying their best to get their community served, and being creative is a great thing. I still go by, when putting the EMR hat, they still have to get their information there somewhere, and we can work on encounter data if it comes in a different format, if they're not billing. For example, the CHC physicians don't bill, their salary-based physicians, but they're still, generators able to still get information from CHC data. In fact, more information than we get in our regular source of information. But I think it's, I almost feel like it's a wonderful model, because the idea is getting rid of the risk and the administration of starting a practice, which is very intimidating. When when some of the young learners are coming out with enormous debt, they're going to cities that are enormously expensive, and it's not economically feasible for them to set up in an expensive city, and they would like to live elsewhere. So to sort of take some of that administrative burden away would be helpful. There's still administrative burden in clinical care that's got to be addressed and is overwhelming and getting worse. So I think, Colleen, I think there's definitely a way that we could catch data in non-traditional formats. That's one thing at ICS is it's been very, it doesn't just stick with this is the data we're going to collect and we're not going to change anything. It gets progressive. For example, I know at ICS, we're looking at more social determinants of health data. We're going to be accessing data from education, for example. And they're also looking at getting more prescription data and looking at community pharmacists to get data from community pharmacists to look at prescriptions, not just for people on ODB over 65. So I think we're kind of always looking, where's the new place we have to engage? And I think, if this is something that really gains traction and their communities are now hiring physicians on a salary basis, I think we'll figure it out.
And maybe, excuse my ignorance, Liisa and Colleen, but wouldn't that model also depend upon the OHIP billing? I know the boutique clinics, which are private clinics, continue to use OHIP billing. The municipalities don't have a bottomless budget in terms of supplying these. I would imagine they work in conjunction with OHIP, Lisa?
Yeah.
You know about that?
Yeah, they might shadow bill. For example, they're still going to shadow bill it some way. I think it's what they're putting. Yeah, I agree. I don't know if any municipality can afford to hire physicians. We're expensive, we're pretty expensive body things. So, yeah, I think they're going to they might cover some costs of practices and startups and access bonuses and all sorts of things. But, they're going to put the carrot out, for example. But, oh, I want them to have carrots for us old fart physicians and keeping me going. I'm waiting for that carrot. But,
So it's now 12:58. Great session. Thank you very much, Lisa, for coming and sharing your knowledge. Maybe I'll put the last comments over to you, Catherine, the director of HSPRI.
Oh, I just popped a thank you in the chat, Lisa. And that was really excellent. So much discussion could happen with this, and I love thinking broadly about the ecology, and it just again brings up more questions than answers, which is always good for researchers.
yeah.
So, thank you so much. I know you probably have a 1 o'clock patient, so we'll let you go.
Well, and thank you very much. And it's very nice to
Thank you, Lisa.
to
That was
talk
lovely.
research.
Bye, everybody.
Bye-bye.
Bye.